Thank you very much to the company for inviting me. It's an honor to be here as every year. Angina was first described about 350 years ago, and it's still a problem. What I'm trying to do in the next 6 minutes is to pose 4 challenges to the current concept of angina. So I do have a 1.5 minute per challenge. It's already a challenge in itself. This is my conflicts of interest. Angina is still a problem, not only for me presenting this slides and this presentation and the concept, also for 100 million persons in the world. 10% to 15% of those have refractory angina. This means that the patients have angina for more than 3 months, and this angina is refractory to any attempt at improving the symptoms of the patients. The reason for this unsuccess is that we actually are successful in reducing the incidence of coronary artery disease. It went down in the last 25 years by about 35%. And we're even more successful in reducing the mortality from coronary artery disease. It went down by about 60% in the last 25 years. That means that there is a 25% gap of patients that live with angina. And I truly say I had a patient yesterday that came to my office and she said, this is not life because of angina. Now, one evidence in this field is that angina does not kill. However, it causes a poor quality of life. There is a very weak relationship between degree of symptoms in angina and mortality. This relationship does not exist, for instance, for cancer, or it doesn't exist for heart failure. The larger the symptoms in those diseases, the higher the chance of mortality. In coronary artery disease, it's not the same. Patients live with angina and conduct a very poor life. Now, the second challenge that I wanted to pose to you is that in the past, we have focused very much on very important endpoints, mortality and myocardial infarction. This was the primary endpoint of all the big trials that we've read in the major journals. But we totally neglected other endpoints that are actually very important to the patients. Quality of life, symptoms, dyspnea, angina, exercise capacity. Patients want to walk up the stairs. They want to survive, of course. They don't want to have infarction, but they want to walk up the stairs because that changes their life daily. And the next challenge is that we focused on one source of angina. Of course, we know that there is demand angina, the third one from the top, that would be this one here. There is supply angina, so patients with anemia, for instance. But what we focus on in our hospitals, in our cath labs, and in our private practices is this source of angina up here, so the epicardial stenosis. All the tests that we have, scintigraphy, stress echocardiography, invasive coronary angiography, FFR, they focus on epicardial causes of angina. But there is a huge fraction, 50% of the patients with angina have microvascular disease, and there is no real treatment for this condition. And then there is at least two different phenotypes of angina. One is chest pain, pressure, a sense of pressure in the breast, and then there is cardiac dysfunction caused by recurrent angina, recurrent ischemia, and hibernation, as discussed in the previous symposium. Now, the next concept that I wanted to challenge is the concept that in the cath lab, with our normal stents or our drugs, we can address all sorts of angina and all sorts of ischemia. The patients are interested in walking up the stairs. The patients are interested in doing their normal life, the normal daily activities of life. And they want to come to the threshold where they can conduct a healthy life, or a life where they can live with their grandchildren or with their children happily. So our goal is to choose for them the best therapy, the therapy that is connected with the least risks among those that are available to fill this gap between functional capacity and symptoms. Now, we have to base our decision on efficacy in terms of how much angina can be reduced. We have to base this decision on risk. which is often very neglected by interventional cardiologists. We have to base our decision on life expectancy of the patients and the durability of this intervention that we start. 70% of the patients treated with optimal medical therapy still have angina a year after randomization in the ischemia trial. 25% of the patients with angina in the ischemia trial showed still complained about angina when treated with revascularization, PCI or cabbage. And if we want to fill this gap, we have now a new player, a new device that maybe be the fittest one for this patient here. He has a CTO, very complex disease, multiple vessels being involved, one CTO, complex intervention. He was 91 years old, frail, but still had angina. He needs to have the treatment that is associated with the lowest risk for this, for his advanced age. So I addressed the question whether there is a need for a new device and a different approach to angina. The next speakers will address the question whether treatment is feasible, whether treatment is efficacious, and whether it's safe, probably with a better English grammar, a better accent. Thank you very much.
Tommaso, you very elegantly described the incidence and the problems and the daily problems that we face with our patients, and there is definitely a need for that. But in your practice, how do you find these patients? I mean, very often we get the questions of, yes, there are a lot of patients with refractory angina, but if you talk to cardiologists, we can solve everything with PCI. So how do you find these patients?
Yeah, the problem is not really how I find the patients or how the patients find me, actually. So you have to raise awareness on the fact that there is this patient, that lots of patients after optimal therapy, including interventions, still have angina. And most of the colleagues, or even us, tend to forget about those patients. We remove them from our consciousness because they're seen as failure. So it is important to raise awareness and spread the word that there is something new. There is something that is actually at least as effective as a stent to treat those patients. Yeah. So those patients have to be made aware that there is indeed another therapy.
And if you're selecting these patients, do you need proof of ischemia, and what kind of test are you performing to show that there's indeed ischemia, or are you relying on the story of the patient itself without any objective tests?
So we're talking about the reducer now. The certificate says that there has to be evidence of non-invasive evidence of reversible ischemia. Now the definition is a bit mixed. I have some problems with this definition, but still, there are at least two groups of patients that deserve the reducer. One is the patients with coronary artery disease, epicardial coronary artery disease that cannot be treated by stents or by bypass. For those patients, I do want to have one of those standards tests of ischemia, stress echocardiography, scintigraphy, that shows hopefully an ischemia in the anterolateral wall. This will be the best target for the reducer, even though the device works also for CTOs of the right coronary. That has been shown in studies. And then there is patients with microvascular angina. And to me, the evidence of ischemia in those patients is an invasive measurements of pathologically increased coronary resistances. And this is what microvascular dysfunction is. And when connected to symptoms, this is an indication for me.
In your experience, Tommaso, I can understand that it may be easier to convince a patient with obstructive coronary artery disease to implant a reducer. But in patients who have no obstructive lesions at all, is it, in your experience, difficult to convince patients to get a reducer?
No, I don't think so. Of course, you have to explain to the patient what the problem is, but I don't think that it's more complicated. In my own experience, I have honestly said, I have a 40% chance to treat a microvascular angina with medications, and a 75% to be successful with the reducer. So.
Yeah, along the same lines, we had a question from the audience, and it's specifically in women where you have a problem with sometimes very atypical chest pain. So what kind of tests do you do here in these subset of patients before implanting coronary sinus reducer?
So if we're talking about microvascular angina, then of course IMR is my favorite one. CFR, second favorite with a normal FFR. So this for sure. Acetylcholine testing, no, I'm not convinced. I'm not convinced that the reducer is the best therapy for spasm.
Okay, thank you.